All right. So my talk today is about hyperparathyroidism and its etiologies. And I decided to do this because it seems like I'm getting a lot of referrals here in Morgantown with patients with hyperparathyroidism. It's interesting because I trained in Marshall, which is about 4 or 5 hours down south of the state. I didn't get a lot of hyperparathyroidism patients, so maybe it's something with Morgantown or the surrounding area, but I do see a lot of these patients. So definitely we'll go over the different causes of hyperparathyroidism and maybe come up with strategies for managing or even catching something that may look like it's hyperparathyroidism, but likely it's not, but definitely we'll go over that. So what is hyperparathyroidism? It's defined as an increased activity of the parathyroid glands. So there's 3 different causes of hyperparathyroidism. One is primary, secondary, or tertiary hyperparathyroidism. Now, primary or tertiary hyperparathyroidism, it's due to an intrinsic abnormal change altering excretion of the parathyroid hormone. So meaning that in these etiologies, primary and tertiary hyperparathyroidism, your parathyroid is making parathyroid hormone on its own without any regulation, without any stimulus. So it's doing that on its own. It's an autonomous secretion of parathyroid hormone. Now, secondary hyperparathyroidism, that's due to an extrinsic abnormal change affecting calcium homeostasis. So this is usually due to a response in the body. There's a deficit in the body, so parathyroid hormone secretion is a response to it. It's making up for what's something happening in the body. And we'll go over the etiologies that can cause secondary hyperparathyroidism, like the others. So primary hyperparathyroidism is the 3rd most common endocrine disorder. And vitamin D deficiency and CKD, chronic kidney disease, is the most common causes of secondary hyperparathyroidism. So this is just a little cartoon of the thyroid gland. And as you can see, there are 4 parathyroid glands that are embedded in the thyroid. And, you know, these parathyroid glands secrete parathyroid hormone. Parathyroid hormone is for calcium homeostasis, as you guys know. So we'll go over some physiology. So parathyroid hormone affects 2 organs in the body. One is in the bone, one's in the kidney. So for the bone, what parathyroid hormone does, it stimulates the osteoblasts, which are the bone building cells of the body, to secrete a chemical substance called rank L, or rank ligand. And this in turn, rank L, affects the osteoclasts, which is the bone resorptive cells of the body, and it initiates bone resorption. So in general, what happens is that increases the calcium levels and the phosphate levels in the blood. So that's what parathyroid hormone does in the bone. Now for the kidney, there's several different mechanisms of what parathyroid hormone does. So in the kidney, parathyroid hormone increases expression of alpha-1 hydroxylase, which is an enzyme that converts vitamin D to active vitamin D. And then active vitamin D acts on the GI tract, and that increases the calcium in the blood by increasing calcium absorption in the diet. So that would increase the calcium in the blood, and also affects different parts of the kidney, especially the tubules. One is in the proximal convoluted tubule, the PCT, that increases the urination of phosphate and decreases blood phosphate. And then it acts on the distal convoluted tubule in kidney, and that increases the calcium in the blood and increases the phosphate excretion. So in general, what happens is parathyroid hormone increases calcium and phosphate in blood, but in the kidney, increases the calcium, serum blood calciums, and decreases by excreting phosphate. So that's what normally parathyroid hormone does. And as you can see, this is a little cartoon as here that kind of explains it more. If you're visual oriented, as you can see, PTH affects the bone and then the kidney. And then like the different steps about the calcium as well. I'm sorry, the active vitamin D working on the small intestine to increase calcium. Now, so primary hyperparathyroidism, the most common cause is solitary parathyroid adenoma. And that's 80% of the causes of primary hyperparathyroidism. But there's also parathyroid hyperplasia, parathyroid cancer, multiple endocrine neoplasia type 1 and 2A. Those are genetic syndromes, and hyperparathyroidism is part of those genetic syndromes. So the defining characteristics of primary hyperparathyroidism are the laboratory work. In these patients, you'll see an increased blood PTH, increased blood calcium, low blood phosphate, increased urine phosphate, and increased urine calcium, which is pretty defining. So the increased urine calcium, usually you don't have an increased urine calcium, but in primary hyperparathyroidism, the PTH is so much that it increases your blood calcium levels. And there's so much blood calcium, there's so much calcium in the body that you're excreting it in the urine. So that's why it's a pretty defining thing to have in primary hyperparathyroidism compared to the others, that there is urine calcium increase. Secondary hyperparathyroidism, you would think due to low chronic low calcium states. So the most common cause is really chronic kidney disease. And in chronic kidney disease, there's a decrease in your glomerular filtration rate. You're not excreting the phosphates as it normally does. And so your phosphate levels increase. So what phosphate does actually binds the calcium, and it lowers the blood calcium. And in lower blood calcium, parathyroid hormone is increased to compensate for low calcium. Also, in chronic kidney disease, we talked about the proximal convoluted tubule and distal convoluted tubule, and there's defects in that, and that would increase the blood calcium and lower blood, increase blood phosphate and lower blood calcium. And then for it also, so in general, in chronic kidney disease, you're not producing calcium as effectively as they should because the kidneys are affected. So that overall increases the parathyroid hormone production. So you will see an increased parathyroid hormone in CKD. Now, vitamin D deficiency is interesting. I would have to say that there's a lot of people with vitamin D deficiency. I was told by one of my co-attendings that this area doesn't have a lot of sunlight compared to the other areas of the United States. So a lot of people have vitamin D deficiency here. So remember what we said, that vitamin D, what vitamin D does, it increases blood calcium or increases the calcium in the body by increasing the reabsorption of calcium in the diet. And you always have to think about in patients with vitamin D, not only patients who are, the low sun exposure or they don't take enough vitamin D, but also you have to think about patients with malabsorption syndrome. So if patients have any Crohn's disease, celiac disease, a more common thing we see nowadays is gastric bypass surgery. So a lot of these patients have innate vitamin D deficiency. And you'd always see that their parathyroid hormone levels will be elevated because they're not absorbing the vitamin D and calcium for that matter. You can also see secondary hyperparathyroidism. I'm sorry?
This is Dr. Paliwal.
Hey.
Actually, I see a rectangular, like a dark shadow on your slide. I mean, is it there? I mean, I cannot see some of the content of the slide on the right side. I don't know whether everybody else is seeing or is it just me?
Dr.
Yeah, it moved. Yeah.
It moved there.
Wait.
Okay.
Oh,
okay.
is it the
formatting of the PowerPoint slide? Oh yeah, it looks
yeah.
like
Yeah. Now I can see clearly. Yes. Thank you.
I'm so sorry. Is it?
No worries.
Yeah,
it's
weird.
just one of those like Zoom glitches on our
see.
end. Sometimes if you have us on your left side, like the participants, it'll show kind of like a black box, but looks great now. Thank you.
Yeah, you let me know. Yeah, I'm sorry that was a problem. Okay, well, I'm glad that's fixed. So let's see. Right, so in vitamin D deficiency states, you would have a decreased increased parathyroid secretion. Now, patients with pancreatic insufficiency, know that in patients with diagnosed pancreatic insufficiency, something wrong with their pancreas, they lack pancreatic lipase. So what pancreatic lipase does, it breaks down the fats, right? That's what it does. But know that vitamin D is a fat soluble vitamin. So if you have pancreatic insufficiency, you're not absorbing vitamin D as normal as you should, and you would have vitamin D deficiency, and you would see an increased parathyroid hormone in these patients. And of course, it's a rare thing, but any patients who are calcium deficient in their body, low calcium states would increase parathyroid hormone production. Something that we really don't see, but something to be aware of, is tertiary hyperparathyroidism. This is usually due to chronic kidney disease that's long-standing, patients who have end-stage renal disease. And as we know, in chronic kidney disease, it's a low calcium state because your kidneys are not functioning properly. So your parathyroid or your parathyroid glands are compensating by increasing parathyroid hormone. So what happens in tertiary hyperparathyroidism, that these glands, because of prolonged secretion parathyroid hormone, they become hyperplastic, and they lead to development of adenoma. So it becomes an autonomous secretion of parathyroid hormone gland, parathyroid hormone, despite having the problem with chronic kidney disease. So you'll see that in patients with CKD and end-stage renal disease. So the clinical manifestations of primary hyperparathyroidism, in medical school, we learned that it's bones, groans, and psychic moans. And these are the things that you would see in patients with primary hyperparathyroidism. Patients who have primary hyperparathyroidism, they would develop anything that would decrease bone density. So osteopenia, patients have osteoporosis. Any patients who have a history of fractures that are, they easily have, fractures, not just fragility fractures, but fractures in the body in general, and bone pain. And this is all due to the bone being broken down by the excess parathyroid hormone. You also see patients with kidney stones, nephrolithiasis. As I said, that there's excess amount of calcium. So where does that go? That goes into the urine, and patients develop kidney stones. Abdominal pain, it's pretty interesting, and it's something that's really not really fully explained. But so increased calcium in the body due to parathyroid hormone breaking down calcium in the bone, or increased calcium from breaking down the bone. So what happens is really increased levels of calcium acts on the sodium channels of your smooth muscles, especially with the gut. And that blocks, because you need sodium for the muscle stimulus to contract. Well, calcium blocks those receptors, so you have decreased smooth muscle action in the gut, and patients usually have decreased GI motility, nausea, peptic ulcer disease, parathyroid hormone, increased calcium also. What happens is it stimulates pariah cells to make hydrochloric acid, which is the acid that's produced in the stomach, but excess amounts of that breaks down the stomach lining, causing peptic ulcer disease. And pancreatitis, an increased calcium also stimulates pancreatic enzymes, and what happens is that it starts breaking down the pancreas, causing pancreatitis. Patients who have primary hyperparathyroidism also complain of increased urination, increased thirst, polyuria polydipsia. This is because the excess calcium blocks antidiuretic hormone on the collecting duct of the kidney, and so patients aren't able to resorb water. So all they do is urinate the water. It makes them thirstier, and that's why you see the increased urination and thirst. And patients also could complain of fatigue, depression, altered mental status. And as I said earlier, the calcium, what it does, it blocks the sodium channels for the muscle and the neurons. So patients usually have muscle weakness, fatigue. They also have depression. So really increased calcium is not really good for the body. Now, clinical manifestations of secondary and tertiary hyperparathyroidism, you would really only see things of decreased bone density. Remember that you have decreased calcium, decreased vitamin D. And so you would have patients who have osteopenia, osteoporosis, fractures. They would also develop bone pain as well, like primary hyperparathyroidism. Now, calciphylaxis is interesting. You usually see this in patients with chronic kidney disease or end-stage renal disease, prolonged chronic kidney disease and end-stage renal disease. And that's due to calcium depositions of the blood vessels of the skin, and it causes ischemia. And there's a pretty defining lesion. This is what it looks like. So if you see a patient with this, it's likely due to the sequela of end-stage renal disease, increased calcium would, break down or at least cause ischemia of the blood vessels of the skin. So yeah, that's calciphylaxis. And here's a pretty good cartoon of, the signs, symptoms of primary and secondary hyperparathyroidism I talked about. Now, the diagnosis of hyperparathyroidism, usually in a primary care setting, you get a calcium level, and that's usually elevated. So in primary hyperparathyroidism, you get a calcium level, it's elevated, and then some primary care physicians get a PTH to work it up. And PTH is elevated, it's likely primary hyperparathyroidism. But really what's important to note is the vitamin D. If the vitamin D is normal or elevated, that's usually primary hyperparathyroidism. And the other causes of hyperparathyroidism, secondary, tertiary, vitamin D is actually low. I put familial hypogasalia hypercalcemia here. I'm not really going into detail about that, but that's a genetic, inherited genetic disorder where you would have the same laboratory work as you see here with primary hyperparathyroidism, but it's due to a calcium sensing receptor in the parathyroid gland. It's defective, so your parathyroid gland is not really sensitive to calcium, so it would increase the parathyroid hormone secretion and increase calcium. The only way to differentiate that is do a 24-hour urine calcium or creatinine, and then you do a fractional excretion of calcium calculate. I don't see a lot of primary care physicians do that, but you can do that, and that differentiates between primary hyperparathyroidism and familial hypogasalia hypercalcemia. Now, secondary hyperparathyroidism, the laboratory work, you usually see a normal calcium or a decreased calcium. Remember, in these states, it's a low calcium. It's a low calcium state, so that would your parathyroid hormone would be increased to make up for that. And then we all know that in secondary hyperparathyroidism in general, there's a decrease in vitamin D, as we know, because vitamin D increases calcium production. And then in tertiary hyperparathyroidism, the PTH is elevated because it's making it turns into an autonomous secretion of parathyroid hormone, and the vitamin D is actually low. And here's a pretty good table of what I just talked about if you want to see things in the table format. So treatment for primary hyperparathyroidism, if that's confirmed, it's parathyroidectomy, that's a surgical consultation. Calcium mimetics like cinacalcet, if patients refuse to get a parathyroidectomy, you can go this route, or if they're not surgical candidates. And what calcium mimetics like cinacalcet, it just increases the sensitivity of calcium to the calcium sensing receptor, so in hopes of lowering the PTH production. Now, secondary hyperparathyroidism, this is usually due to CKD or chronic kidney disease and vitamin D deficiency. You can use phosphate binders. Remember that phosphate binds calcium. So if you bind the phosphate, your hope is to increase the calcium or put it in a normal range. Vitamin D replacement is really important in patients with secondary hyperparathyroidism because, like I said, vitamin D increases calcium absorption in the gut. And you can also use calcium mimetics. This is usually in the setting of chronic kidney disease, just to decrease the parathyroid hormone secretion. And usually it's so that's what it does. I don't know if you guys can see this, but this is the the guidelines for parathyroid surgery in primary hyperparathyroidism. I don't think a lot of primary care physicians refer these patients straight to surgery. They usually go through us first, from my experience, but if you want to do it, you can. So patients who have an increased blood calcium level more than 1 milligram per deciliter, so that's usually around 11, surgeries indicated. If they have signs of osteoporosis or fractures, surgeries indicated. If their kidneys are affected, so creatinine clearance is less than 60. If you do the 24-hour urine calcium, it's more than 400. If they have a history of kidney stones, surgery is indicated. And if everything else is negative, patients don't have this, but they're less than 50 years old, surgery is indicated. So this is an important slide. I just put this together. Things to consider. Especially this is applicable in a primary care setting. So things to consider when you're working up patients, and not so much the hyperparathyroidism or PTH aspect of it, but more the calcium. So always do a corrected calcium. So when you get the basic metabolic panel, and it's pretty true here and for WV labs, it doesn't have the albumin in it. So the corrected calcium takes into account serum albumin. Albumin actually binds calcium. So even though and that is the formula: serum calcium plus 0.8 times 4 minus serum albumin. So albumin actually binds calcium. So when we get these total calciums on a basal metabolic panel, it's not really the true calcium level. Let's say we have a patient whose their calcium level is 10.5. It's pretty high, right? But then what you do is you use the serum albumin to see if the albumin's high, and we know that albumin binds calcium. The corrected calcium is actually lower. It's probably 9.7. So always consider the corrected calcium. This is even true for patients who have low albumin as well. Let's say patients like calcium is like 9.7, but their serum albumin is low. Their true calcium is actually really high. So always consider serum albumin. That's really not in the basic metabolic panel. So if you want to get the albumin, that's usually part of the complete metabolic panel. Now, also, when you're working out patients who have hypercalcemia, you always consider medications that increase the calcium levels. Lithium is one. Thiazide diuretics, we see that all the time. Patients with hypercalcemia, but they're on thiazide diuretics, they don't need to be, you need to stop that for about 3 days and then repeat to see what happens with the calcium level, just because diuretics increase that. And it's because it increases calcium absorption in the kidney. Patients, you have to screen patients with a history if they're taking excess vitamin D, get a vitamin D level. If it's really, really high, then their calcium is likely due to excess vitamin D intake. And patients who are taking too much calcium, patients who take Tums like candy, right? That's excess calcium that can bring up their serum calcium levels. So you have to screen down the history before really thinking or really saying that this is true hypercalcemia, and then you have to get a PTH if it's hypercalcemia. Now, this is from my clinical experience. Even though I said that, vitamin D deficiency, usually patients would have low calcium or normal calcium. I've seen mild hypercalcemia in vitamin D deficiency. Remember, like what happens in the parathyroid hormone breaks down the bone, increases serum calcium. So sometimes you'll see mild hypercalcemia that can occur in vitamin D deficiency. Always check a vitamin D level. Vitamin D, and if that's low, it's likely vitamin D deficiency. And so you have to correct that. And then if the PTH is, you're going to get a PTH, but the PTH will likely improve its vitamin D deficiency. So always treat vitamin D deficiency. And as I said, actively screen for vitamin D deficiency, especially in patients that are high risk for developing vitamin D deficiency. Like I said, here in this area in Morgantown, we're not getting a lot of sun compared to the rest of the country. So a lot of people have vitamin D deficiency. And if you do a laboratory quantum, you'll see that they have increased parathyroid hormone. We have a lot of people now that are getting bariatric surgery, gastric bypass surgery, and the anatomy of the gut is altered, so they're not absorbing vitamin D as efficiently as a regular person. So their parathyroid hormone is always elevated. So always correct the vitamin D deficiency, because the increased parathyroid hormone is likely due to that. So this is just a little, if you want to do the corrected calcium, there's this one I specifically use from MD Calc. This one if you're not really familiar with the equation for that, you can just put in the numbers here and then get the real calcium level. Okay, so that's my talk for hyperparathyroidism. Any questions?
Thank you so much, Dr. Rico. That was really wonderful. I feel like you went through in depth, but also kept it so like clear for people who might not necessarily be too familiar with it. So we just really appreciate you taking the time and
no problem
for us.
Do you mind going back one slide? Oh,
Sure.
I'm sorry.
I just put your slides down, Dr. Rico. I'm sorry about that.
I wanted to write down those normal counts for the calcium and albumin.
Right. Yeah, exactly. So usually I use a 4. The normal albumin is usually 4. So I would do that. 4 would be the normal.
Well, I've just had a huge 5-page long blood work done. So I was going to look at those.
Yeah. So like I said, in these patients, or like our basic metabolic panel does not account albumin. And so we're getting all these patients with calcium, like you have high calcium, low calcium, but you have to put in the albumin to see what it really is. I mean, I've gotten a lot of referrals from patients who are, hypercalcemia, but then their albumin is high for some weird reason. I mean, it's not that high, but it is high. And then if you do the corrected calcium, it's actually in the normal range. So I've had about 3 referrals since starting because of that. So it really is important to get that albumin for sure.
Any other questions from the group?
I have a general question. I mean, what I've seen that whenever the patients are being admitted at Ruby Hospital or WVU setting, I mean, they always get phosphorus as a part of initial blood work.
Right.
I didn't understand what's the logic behind that and what to look for. I mean, can you explain me?
So like I said, in phosphorus, usually it's more the the nephrologist who would usually get phosphorus, but remember, phosphorus binds calcium. So that's why that's usually part of nephrologist workup to get a phosphorus. I don't know why they would get a random phosphorus in any patient. Unless like there is some calcium abnormality, then I would get a phosphorus. But yeah, I don't know why people would usually get a phosphorus. That's usually in the setting of like nephrologists, what nephrologists do.
Okay. And for patients, I mean, whose calcium, I know that if the albumin is good, but their calcium stays close to 11, it's not like 11, but it's between 10.5 to 11, and it's happened many of the times when you do the regular blood work.
Right.
I mean, apart from monitoring, anything else that needs to be done? And vitamin D?
Yeah, so if it's normal vitamin D, slightly elevated calcium, you check a PTH. And so if the vitamin D is good, the calcium's high, and the PTH is elevated, this is likely primary hyperparathyroidism.
Okay. And is there anything like you have to have this in 2-3 settings, or it just one time you checked it and it's high, you should make that?
Yeah, so I usually get a calcium, a PTH, and vitamin D together all at once, and then I repeat it. If it's the same picture where elevated PTH, elevated calcium, normal vitamin D, then I would do the urine calcium just to make sure it's not familial hypocalciuric hypercalcemia, which is that benign genetic disorder of the calcium sensing receptor, versus primary hyperparathyroidism. I didn't go into detail with the urine test, but in the urine test, you do a fractional excretion of calcium, FECA, F-E-C-A, and if it's below 0.01, it's likely not primary hyperparathyroidism. But if it's above 0.01, it likely is, and then that's a surgical referral. I usually, and interestingly, and this is from my experience, I have a lot of patients that I've seen here since starting August with primary hyperparathyroidism. This is the weirdest thing, but every week, I think every week I've been referring at least one patient for surgical management. So I don't know if it's this area in general, but I do see a lot of patients with primary hyperparathyroidism here.
Okay. And one of the thing you mentioned about low calcium intake.
Yeah.
Okay. Now, do you really see that manifesting here?
Not really. Not really.
Okay.
That's like in patients who are really malnourished and not really trying, or the patients who have maybe like malnourished, not getting enough nutrients, but that's usually not the case. Not the case at all.
Okay.
Do you know if this I called it, I put it HT in my notes because I can't get that, string that word together. Does that automatically go along with diabetes, or does it just sometimes go along with diabetes?
From my experience, patients, there's no real correlation, just because diabetes is like insulin resistance, primary hyperparathyroidism doesn't really, it's more calcium metabolism. So I don't really see a correlation between the two per se, just because, like I said, it's just two different processes. I can't think of any genetic syndrome that includes insulin resistance and calcium abnormalities for sure. But like I said, in this area, what's happening is I get a lot of primary hyperparathyroidism patients. It's because the theory is that in this area, we don't get a lot of sun exposure. One of my co-attendings, Dr. Heather, he told me that this area is pretty unique. It doesn't get a lot of sun exposure, even though we do get sun. Maybe it's something about the ozone or everything, but a lot of patients have vitamin D deficiency. So prolonged vitamin D deficiency can cause your parathyroid glands to be hyperplastic just to compensate, and then those develop into adenomas. So like I said, I do want to do like a study later on or something to see what is the cause of increased amounts of primary hyperparathyroidism in this area. Like I said, I trained in Marshall for 2 years, and we didn't have so many patients compared to what I see now. So vitamin D deficiency, very important to screen. Very, very important to screen. I usually screen them for patients not even complaining about it, just because I've done it so many times and people have vitamin D deficiency, and I usually correct it.
No, I was diagnosed with vitamin D deficiency 10 years ago. So I've been taking a small supplement over the counter. I took the big ones first, and then I took the little ones. But my kidney doctor just called and said to go off the vitamin D, and we needed to retake the calcium.
Yeah.
And then it's ironic that you're talking about this HT, as I call it, and almost like it goes along with everything that I've been dealing with.
Sure.
Or maybe I'm just being paranoid since we're talking about it. I'm trying to see.
I mean, to give you perspective, I have pretty bad vitamin D. I just went to my primary care physician about a month ago, and I was like, hey, just check my vitamin D. She's like, are you sure? I'm like, just do it. And it was really low. Like, I'm taking the 50,000 a week because it's so low. So I really think people need to be more aware, especially in this area with the vitamin D deficiency. Because like I said, if you have low vitamin D, you're not absorbing, or you're not getting enough calcium, because vitamin D is a stimulus to bring in the calcium in the diet. And what it does, and then your PTH would increase, and PTH breaks down the bone. So we need to protect our bones. So we need to keep our vitamin D levels up for sure. Any other questions?
These are all really great points, and I've heard the same thing about vitamin D. I'm actually gonna try to get my blood work taken soon too, so I can see, but 100%, I don't think we see enough sun where we are. So
Sure.
But usually you have to ask your primary care physician to take vitamin D, and we even have to pay for it ourselves. But it's not very expensive. It's $10 or something. But just the very idea of something so important that the insurance won't pay for it.
Wow. Yeah, like I said, I screen it for my patients, even if they're not coming in with vitamin D. If they complain of fatigue, they're like, oh, I feel tired, and their thyroid, I just check it anyway, and it's usually low, and I tell them, hey, you need to take some vitamin D.
Thank you. And I saw the chat in from Elizabeth too, saying she takes the gummies. Thank you for that. Dr. Rico, do you have is there differences between the brands that are over the counter that we can just go buy ourselves, or do you have any recommendations on what kind of vitamin D?
I mean, there's the brand doesn't matter. I think you can get it over the counter. So the hard and fast rule about vitamin D is if you don't have any absorption issues or anything, 1,000 units of vitamin D will increase your vitamin D by 10. So yeah, the 1,000, let's say yours is at 20, normal is at around 30. So if you're like maybe 25, you know, if it's slightly below or like near like 21, but not like below 20, I just take over the counter 1,000 units, and that should bring the vitamin D up. Now, it takes about 3 months for this stuff to normalize. So you would get labs in 3 months to make sure that you had an adequate response.
Thank you so much. And Elizabeth, I see you have the bottle with you right there. She was asking, is the 3,000 of it too much of D3?
Not really. And even then, like even though 30 is the normal range, even patients who are to go to 50 or 60, it's fine. Now, if you get over 100, that's considered toxicity. So that's too much vitamin D. So yeah, you could, if you could keep it between 30 to even 50, I think it's okay.
Okay, perfect. Thank you so much for that clarification. And Dr. Polly Wall said, thank you so much for your presentation.
Thank you. Thank you.
Any other questions, comments, thoughts from the group? I can absolutely give you guys 20 minutes back to your day, but don't want to cut the conversation short in any way. So definitely chat in, unmute if you have any comments. All right, and as usual in the recap email, I usually send out the didactic PowerPoint. So Dr. Rico, I'll be attaching your slides to the recap email. So everyone, even off the session right now, whoever's in the listserv will be able to get a copy of those. So if you have an updated version, you can absolutely send that my way, and yes, I'll attach that version. But anytime, that would be great.
Thank you. Thank you.
Sure. The only announcement I have is that the next session will be on March 23rd, and Kylie Lovejoy will be presenting on ADA guidelines. So keep an eye out for that reminder, and we'll see you all next time. Thank you.
Thank you. Take care.
Thank you.
Thank you so much, Dr. Rico.
Thank you. Bye.